Hello friends and welcome back to Dr. A. Sajid. Today we'll be doing a two-video series on the topic of gout. In this first video, we'll be covering up some basics. First, we'll be talking about the signs and symptoms. Then we'll discuss a little bit about the differential diagnosis. We're just going to divide it off into two. We'll talk about the differential diagnosis. Then we'll talk about the risk factors, the diagnosis, and the treatment. First of all, for the signs and symptoms, we're going to pick up NICE guidelines definition, which is basically rapid onset. The second part would be pain, redness, and swelling of first or other metatarsal plus tophi. Now we're going to see what exactly do all of these mean. So it's basically a rapid onset pain with redness and swelling of the first metatarsal base or both the metatarsals. So this should be both or both the metatarsals. Now rapid onset according to the guidelines would be around 6 to 12 hours. And pain would mean inability to put weight, and redness and swelling would basically mean very, very tender to touch. And our tophis would look like chalk-like deposition, which would be subcutaneous. So if we were to talk about the signs and symptoms, basically it would be a rapid onset pain, which would come in about 6 to 12 hours, and the patient's presenting complaint would be inability to put weight on the foot. It would have redness and swelling of the first or both metatarsal, so it would be very swollen and tender to touch. You can't put pressure over the joint, and that would be associated with tophi. Tophi might present in chronic gout only, but the above portion of the definition should give us a lot of aid whilst we're sitting in our practice. Once we've diagnosed gout, we move on to the differential diagnosis, and these are things that we wouldn't want to miss. So number one would be septic arthritis. Number two would be calcium deposition. And number three would be inflammatory arthritis. Now, septic arthritis, I was working with a very, very capable colleague of mine, and he told me that if you're examining a patient with septic arthritis and the patient can fully extend or fully flex, then that patient is very unlikely to have septic arthritis. So an easy way in examination to check for septic arthritis is to perform full range of movements on that joint. And if the patient is able to produce those full movement of joints, it is pretty safe to go against septic arthritis. Unless you've got other features like systemic signs of infection that you're worried about. Moving on would be inflammatory arthritis. For inflammatory arthritis, we're falling into rheumatoid arthritis, osteoarthritis, and this would obviously present in different ways. And stuff like rheumatoid arthritis would have other things going on that would point towards it a lot more. Calcium deposition would be ruled out on a joint aspiration. The risk factors are important because they would help us differentiate and counsel about lifestyle modifications. In general, the risk factors include male, anybody who eats meat, seafood, has alcohol, is on diuretics, and has CKD or other comorbidities like hypertension, diabetes. For our diagnosis, a clinical diagnosis would give us the answer, but we would want to check the urate levels. And according to the NICE guidelines, a urate level greater than 360 confirms gout. In case it is less than 360 and we have strong signs and symptoms for gout, then we'd want to look into repeating after 2 weeks. 2 weeks just to confirm the diagnosis. If we're uncertain about our diagnosis, about what's going on in the joint, then a joint aspiration would be ideal. For the treatment of an acute flare up, so we'll do a part two where we talk about the management of gout after the flare up, but this is where we'll be talking about the acute flare up. And the options that we have over here, number one, are NSAIDs, with of course our PPI cover. These are the first line treatments, and according to some studies, naproxen, diclofenac are the NSAIDs of choice. If there's someone who's intolerant to NSAIDs, for example, somebody who's got heart failure or is in anticoagulations, for them the choice would be colchicine. So that would be in patients with heart failure or anticoagulations. And what's important to remember about these patients would be um, on colchicine would be that they can only do 3 days course at one time, at once. So if you have a patient who's done 3 days of colchicine, we wouldn't want to repeat that and we'd want to go forwards with something else. We've got intra-articular steroids as our choice, and lastly we've got interleukin 1 inhibitors. um Canakumab is one of the examples that needs thorough investigation. So if a patient is intolerant to all of these, only then we can go forwards for an interleukin inhibitor as well. Other than that, what's important is ice on the joint, and counseling is very important. And when we counsel a patient for gout, we'd want to go back to the basics as to what they'd want to avoid. So, meat, seafood, alcohol would be important. And in case if it's a first event, then we'd want to do a medication review because diuretics might be causing the gout in our patient. So that's my summary of the NICE guidelines of gout, where we've talked about the signs and symptoms, rapid onset, 6 to 12 hours. Pain would basically be presented with the patient that they're unable to put pressure on it. And redness and swelling would be when you go on to touch it, they will scream in pain because they cannot bear pressure. Differential diagnosis, septic arthritis with the movements, we can rule it out. Calcium deposition, we'd need investigations like joint aspiration. Inflammatory arthritis would have other features and as well. We've got risk factors that we've talked about. We'll indulge the risk factors with our counseling and medication review to find out and to prevent gout further. Diagnosis is easy, it's clinical. If it's not clinical, we can always add it with the urate level greater than 360. It confirms the diagnosis. Less than 360, like we've talked about, we'd need, and we've got signs and symptoms, we can repeat the test in 2 weeks. If we're always uncertain, or if we're ever uncertain, we'll always have a joint aspiration to fall back on. The treatment itself for an acute flare up would be as follows: NSAIDs, colchicine, intra-articular steroids, and interleukin inhibitors. Um, for the medication point of review, NSAIDs would be the first line, with naproxen and diclofenac being the number one choice. Colchicine with heart failure and anticoagulation would be a better choice, but needs to be given only 3 days in a row and then needs to be stopped. Intraarticular steroids can sometimes be used in acute flare ups as well. Interleukin inhibitors are something that need a recommendation or an advice from the rheumatologist before it starts off. We've got ICE counseling and medication review that will also help our patient. So, this is the management of acute gout, to be exact. We'll go forwards and do, in our next video, we'll do the bit where we talk about the chronic management of gout, and when do we talk about the preventions and how do we follow up a patient who's on prevention medications for gout. If you've liked the video, don't forget to like, comment, and subscribe, as it helps me grow. Have a good day, guys. Bye.